This is Chapter 5, a recorded lecture for the healthcare analysis, or excuse me, HSC 400. And in this chapter, we're going to really talk about data quality and governance, which is really, we're talking about sort of creating, maintaining, preserving, storing data in a manner that gives you a high quality result, so that there's an old saying that, as I often use all the time, it's called trash in, trash out. And that really applies here in the sense that if you collect data in a corrupted manner, then you cannot do any analysis of that data, or you can't do any substantive analysis on that data or any accurate data analysis, because you're starting out with information that's not accurate. So that's one of the big issues. Then governance, how to manage that process formally through assignment of responsibilities to certain people. So we'll look at the first, the introduction. We know that healthcare leaders should really, we said this again and again, and I'll say it more times than not, is healthcare leaders should rely on making decisions and evaluate quality and performance using data and with the best possible data. Now, you don't always have everything you need to make a decision. There's Peter Drucker once said something I thought was really important, and he said that most good leaders make decisions with about 70% of the information available. If you make decisions with something less than 50%, you're flipping a coin. That's not really a good leader. That's just good luck. And if you wait to make a decision until after you have more than 70% of the information, usually the decision's already been made for you. In other words, you don't really make the decision. The events make the decision for you. So good leaders really who have some effect on how things are working out and can make change will make that decision at 70%. And they do that with data. They don't do that with emotion or gut feelings or whatever that is. Having good data for analytics and quality improvement begins with effective management of that data. And like I said, effective management in the sense of making sure that you collect it correctly and that you maintain it correctly. Always remember, data is not a chair. It's not a static asset. A chair, if you put it in a room and you come back in 5 hours, it'll be the same chair. Data, if it's collected in a 24/7 sort of way, that data will change 1 second after you do your report. 1 second after you analyze the information, because it's constantly changing. It's very dynamically changing. It's an extremely valuable resource, but what happens in 1 minute will be a little different the other minute. Now, there are trends that you'll see. If you have a place that's trending badly, 1 more minute is not going to make it suddenly look great. But it is different. Now, some activities associated with our data system management include what's called data modeling, and that's a wayfinding tool for both business and IT professionals. It uses symbols and text to precisely explain the information. Data creating, that's literally creating through day-to-day operations collection the raw material, and data is raw material that becomes the information. So data creating is the manner in which you collect it. Data storage is really how data is stored in a database to improve efficiency and accessibility. And that sounds like it's very simple. You just put all in a big pile and you take it out whenever you want. How you put it in that big pile is pretty important. Imagine if you, the old needle in the haystack analogy. If I put a needle in the middle of a haystack, finding that needle is pretty tough. You may find it, but it's going to take a lot of effort. On the other hand, if I take that needle and put it in a big silver box and set it on top of the haystack, find the needle is pretty easy. And so understanding how to store data so that the right information is accessible without excessive preening and working. And then data usage. The main purpose of creating and storing data is to use that data. And analytics is one of the primary ways that healthcare organizations really can utilize that data. Now, the need for efficient data management, HIT, Health Information Technology, we utilize EMRs and other clinical systems that continues to expand and expand and expand. In fact, the U.S. is far behind other industrialized nations using EMRs. Most of the other industrialized nations are about 90% EMR leveled. I mean, they're using EMRs in their medical facilities. In 2009, I believe we were somewhere around 29 or 30%. I know that there's been a lot of push to make that better, and that the government has created subsidies for medical centers, medical delivery systems, to add the EMR to their system because they really want them to do that, to make the information portable and sort of searchable and analyzable, if you will. But what we're seeing is that we're really a little bit behind everybody else. Now, to show you how healthcare information systems are generating volumes of data, in 2011, we created 150 exabytes of data in the United States. Well, what does that mean? Well, a gigabyte is 10 to the 9th bytes. An exabyte is 10 to the 18th byte. So you can see that that's a logarithmic number. So it's a multiples of 10, if you will. So it's instead of 10 to 9 zeros, it's 10 to 18 zeros. And you start thinking about that. That's an extraordinary amount of data when you think how that's happening. Now, when you look at data use for healthcare quality improvement and process improvement or project improvement, it has to be high quality. It has to ensure that the information is generated from analytics is valid and useful. So collecting data it has to be high quality. That sounds like an easy thing to do, but there are some very simple corruptors that happen in many medical delivery systems. For instance, let's say you go, the medical delivery system has a radiology section and a lab section and the registration section, and you go in and you put your name and address down in one place. You go to another place and they put it down a little differently. And you go to the third place, they put it down even more differently. So all of those are just your name and address, but they're done differently. Maybe one of them made a mistake. Maybe they mistyped your name or mistyped your address or put the wrong number in your house number. So all of those can interact and corrupt each other. You have to well document so that analysts and developers using the data are aware of its content and meaning, so you know what you're looking at and what it contains. And it has to be easily accessible. You need to worry about security, of course, and you do need to worry about maintaining privacy and all of that, but you have to make it accessible for analysis, and that's important. So it has to be available in a data warehouse or data store to ensure the availability for analysis. So that's kind of an important thing. You have to look at that, maintain that flexibility. Now, healthcare organizations as data owners, they have responsibility to ensure that the data quality and the determined data quality level is necessary in different fields in the database, because different fields have different requirements. Different data fields require different levels of quality, like I just said. Also have to maintain security and privacy. They have to determine who has access for what purpose. And analytics should always use what's called anonymized data. That means anonymous data. Shouldn't be any individual information in their studies. They should be able to say, you know, all people with a social security number of whatever have this disease. That's really not what they're doing. They're looking at the strata that they develop is really to look at across different people, maybe the same disease. Maybe look at all the people with the same disease. And truly, if there's only 2 people with that disease in your hospital, that would be, you know, it wouldn't be quite anonymized data, but you get the idea. You don't use their name and all of that. Now, business rules are the rules to validate, map, calculate, and transform raw data into usable information. Availability means information must be available and downloadable whenever needed, and try to approach that 24/7 operation. It's really interesting. Data used to generally only be available when the IT guys were in the office, and that was usually between the hours of 8 and 5. Well, at 6 o'clock at night, you suddenly have a crisis and you need to pull data out. You couldn't get it, so you call the IT guys back in to open the data up, which is kind of funny when you think about it. Now we've got a different approach where we realize that data shouldn't be limited to certain hours of the day, the access by the people that need it. And secondly, it shouldn't be limited by where you're at in the world. If you need that data in Tuscaloosa, Alabama, and you live in Albuquerque, New Mexico, then you should be able to access that data as long as you have the credentials and you have the right to have that data. Periodicity is data needs to be updated and refreshed as often as possible to ensure information is up to date as possible. Now you'd be surprised. I was a consultant, and I went to this medical delivery system. It was actually a series of clinics, and they would upload their data from their clinics once a month, and they would make decisions based on this 1-month snapshot. Well, every month is different, so they couldn't make changes. They didn't know how to look at data from seasonal variation. For instance, you see more patients at certain times of the year than at other times of the year. Certain diseases you see more of in certain times of the year than other times of the year. You know, the flu season, which used to be the flu season in October and March, so to speak. Now it's year-round, but the flu season. So the idea is that they weren't really looking at up-to-date data. They were looking at snapshot data. They were looking at 1 month, and so the leaders of that multi-clinic system would make decisions about people and clinics based on what they look like for that 1 month. So if their profit was down and their expenses were up, then they would, you know, browbeat them or beat them up or fire them based on that result. Even though every business that goes through the ebbs and flows through a yearly, you know, alteration, yearly process, and so they didn't really look at long-term data. The second thing is they were downloading data only once a month, so they didn't really see variation in a month. Sometimes in a month, you're busier in the first 2 weeks of the month, especially if the people that are coming to your clinics are paying on their own. They'll pay when they get paid. And so they try, if they're coming for preventive health care, regular health care. So they'll come in the early part of the month because they have money to do that, and towards the end of the month they're worried more about things like food and gasoline to get the car to work. So it's even those variations take place. So it's kind of important to sort of understand that, and when we sort of told them that, they were shocked that we would even want them to go to that trouble, because they had one total IT guy doing all this for them, and he was just overwhelmed, and it became clear to them after a short period of time that they didn't have the people in IT, number one. And two is they had data, but they weren't using it at all in any constructive format. The other part we got to think about is performance. That's the response time for users to access the system. Shouldn't take a day to get into the system. It should take seconds. It should be an easy process, at least for the people who have access. When you look at data quality, the most important aspect of any analytic system is obviously access to accurate and high quality data. I can't say that enough. Collecting data just to collect data isn't very good. Now, I have had to do analyses on dirty data that wasn't always the cleanest it could be, but it was consistently dirty. You know what I'm saying? It's kind of hard to say it that way, but it was consistently dirty. So you could do analysis on consistently dirty data, and you could do some trending on that, understanding that it's dirty data, but you can do some trending on that to make at least somewhat of an informed decision based on what you have. As you clean up the data, that gets better. But the dirty data, sometimes that's what you have. Now, the lack of high-quality data affects quality improvement projects, process improvement projects negatively, because they may think that they're doing something to improve the system, and in truth, it doesn't need improved, or what they're doing is an improvement. Healthcare organizations need to determine their own quality requirements, but they need to try to maintain a standard, and they need to look at their fellow colleagues and how they do that standard. Now, data quality, these are the data quality dimensions. You have accuracy, and that reflects how well information within or otherwise derived from data reflects the actual reality of what you're intending to measure. That's important. Timeliness is important. How recent is the data? Having data for 20 years ago is not very helpful. Having data for 10 minutes ago may be more helpful, unless the information you're worried about is what happened 1 minute ago. So timeliness is important. Comparability. I was stationed at headquarters in United States Air Force in Europe, in Ramstein, Germany, and I was at we'd get these presentations by people who would give us data one time, and then the next time we'd see a wholly different result, and we'd ask why, and we'd say, well, we added up different this time. And it was like, well, then how can I compare what's been happening in the past to what's happening in the future? You've given me no tool to show how that happened. And so what you've done is you've created a new paradigm, a new data set, which is not comparable to the old data set. And so it took a while for them to understand that. Has to be usable. Has to reflect how easy it is to access, use, and understand the data. So it has to be available. Has to be relevant. Has to reflect how well the data meets the current potential future analytics needs of the healthcare organization. And by the way, that changes from time to time. As an organization grows, the data you need is different. We, as a consultant, went into a place, to a multi-hospital organization that had started out as having one hospital. Within 3 years, they owned 7 hospitals, and it was in they were a large city, and then they had these little towns around them, and so they had smaller hospitals around them, and they bought them out. Well, they were still collecting data on the main hospital, but not on the little hospitals. And they were wondering why their bottom line was starting to fall, and the answer is they weren't measuring anything from the little hospitals. So little hospitals were, some of them were were not making money in the first place. They were insolvent, and they had added those to the whole, and yet they hadn't taken into account what they had to do to fix that. So the information has to be relevant. Completeness, and that refers to how much of all potential electronic data, for example, health records, claims, and all other sources, is available for analytics. You can't just look at one small part of a database and there's other information throughout the database. So it has to be complete. Conformity reflects how well the available data conforms to expected formats, such as standardized nomenclature. If you have one group of people that are putting in using one set of nomenclature for the same thing, and somebody else using a different one, that is a big problem. Now you can put in translators and you can do all that, but that just adds multiple levels of complexity that aren't necessary. Consistency measures how well the values agree across data sets and the extent of agreement exhibited in different data sets. So what we're saying is that it has to be consistent. So what you deliver is a consistent sort of message. Now, achieving better data quality, good data does not guarantee effective quality improvement and process improvement, but bad data will definitely reduce those odds of success because the data can't be trusted. And if you have people that you're trying to ask for change, and I'll give you physicians and those kind of people, and you give them bad data, they will never trust you again. They will think you're trying to trick them. So they may not understand the statistical significance of something, but they'll understand when it's not true. And if they can find out that what you have is not true, whatever you do from there on out is very helpful. Now, according to, if you look at back in TQM, Total Quality Management, one of the authors of that was Joseph Giron, and he said that data are of high quality if they fit for use in their intended operational decision-making of the role. So having data needs to fit for what you need. If you're collecting data that doesn't give you the answers you need, then there's a fix for that. And that is collect data in a way that does that. To achieve good data is really hard work. You have to start by optimizing the source of the data. Like I said, trash in, trash out. If you put garbage in, you're not going to be able to get anything magic out. If you put cow manure into the system, you're going to get cow manure out of the system. Analytics can be used to help monitor and coach staff to collect data as accurately as possible. And sometimes you can use it to improve the system. So like I said, the analytics can go back and say, okay, we're going to start measuring how the data goes in. In my background, I was the COO for a radiology group. And they were always complaining that the payments from CMS and the payments from insurances were always a problem because they had to resend things back because the data that they got wasn't very good. Well, it turns out that the floor manager had been pushed to increase the quantity of keying in that was being done by the data entry people, and she was starting to give them bonuses based on how many records they put in. She didn't look at the quality of those, she just looked at getting it in. So they were rushing to get stuff in, but they were putting out crap. And so we changed that motivation. We said that you'll get a bonus every month based on your productivity and based on the quality of what you turn in. Those two things will have an effect. So if you're the highest in productivity but your quality is crap, you'll get a much smaller bonus than if you have high productivity and high quality. And we instantly changed our data entry, and our return on our first submissions for reimbursement went from about a 40% level to about a 92% level. Literally, we were getting money back in half the time and half the work, because remember, we had to have data people reinsert that data all over again and correct it so they could fix it. It was a mess, and it was just interesting. Now, the best approach to improving the quality of HCO data, healthcare organization data, is to prevent data quality issues in the first place. And I've said that. Let me say this again: trash in, trash out. Say that to yourself every time you're managing that, and make sure that what you're getting in is what you want to get out. Poor data is usually a result of how users interact with clinical or other information systems, and sometimes poor data is just a result of errors in the interface codes between the two systems. It may not be a human problem, it may be a coding problem. I'll tell you that most of the time it's a human problem. If it's a coding problem, that's an easy fix, because you can go back, change the codes, reinsert the data, and refilter the data, and it'll actually clear up. Cause of poor data quality: if you have no data available, that's in part due to not being fully computerized. It is almost impossible to collect useful data with a paper trail. because you have to have people go through and analyze each and every record involved in the data you're searching, and then they have to have standardized methodologies for inserting that data electronically, and then you go move from there. So what we're saying is that a computerized system is much more accurate. It's because it doesn't have the human error part in the middle of transposing it. It is more accessible. It's pretty important. Now, data that doesn't represent workflows is not very useful. And with EMRs and other automated, computerized, and data collection systems, data management procedures and processes have not kept up with the advances in technology. So what that means is we're still collecting data, just like the people that bought 6 more hospitals from 1 to 7. They weren't collecting data that represented what they were doing. And so you have to make sure that your data the data collection is reassessed on a regular basis to make sure that it's also dynamically changed as you grow. If you add a new department, let's say you decide to add an oncology department, you have to collect the information on the oncology department, and you have to look at how it affects the whole. I remember when I was administrator for Loveless Health Systems in Albuquerque, they suddenly decided to buy 5 clinics, and they were the people that after they bought them, the people, the governing committee said that, man, we spent a lot of money and didn't get much back because they weren't making a lot of money. Well, until we looked at the fact that those clinics were now referring all of their patients to the specialists at Loveless, and all the second level money was coming in, we realized that they were more than paying for their work. We had to improve their quality of collection and improve their productivity, but what they were doing was definitely paying they were covering their costs. So it's just understanding that. Personal inclination. Staff doesn't follow the procedure and they start doing workarounds. I will tell you that happens 1 minute after you establish a process, unless you measure the outcome data, the outcome results. So in other words, if I go in and make a change in a work process, if I don't follow up, if I don't continually monitor that for an extended period of time till it becomes the way we do things, so to speak, it will revert back to the way we used to do things almost immediately. So one of the ways that you make that happen is you have to make the revert back part impossible or painful. And so people are just sort of, they have to go forward. Data errors, human error can create media data errors, like I said, misspellings, incorrect medical record numbers. Those are very common causes. And so that trash in, trash out, that's what you're seeing. Now, the root causes for poor data quality can be, like I said, the multiple data sources. And I talked about having your name and social security number and address coming in from different sources, and that's one of those things. Or patient demographics could be established differently. I'll never forget, I had a patient come to us one time when I was at Loveless who complained that they were getting like 8 bills from us every month. Well, what happened is that they'd come in for a kind of a long stay, and their information had put into different systems before we went to a consolidated system, and they were all different names. So the billing system saw them all as different people, even though they had the same address, and they sent them 8 bills, all of which were, different bills, but some of them were replicated, some of them were, were independent, but they were different bills, and they were trying to figure out what was going on. And once we figured out what happened, we were able to consolidate their bills and do the kind of things we were supposed to do in the first place. Subjective judgment in data production, lack of clear documentation and definitions can result in staff interpreting how to collect the data differently. So in other words, if you don't have very clear, precise directions, the staff will fill in the parts for you. And each staff member will fill it in as it's convenient for them or as they think it should be. And those will all be different. If you look at Six Sigma, the approach that they say, and that variation is the death throw of any organization, you will get multiple variations. And the longer a process is in place, especially if it's not measured, the more variations you'll get from person to person. Security accessibility trade-off. If the security is too tight, developers and analysts may go elsewhere where data is more accessible but less quality. In other words, you don't want to, if you need to turn in a report or an analysis and you can't get into the data in one place, you'll get it to another even though it may not be as good at data. Coded data across disciplines. In other words, different source systems may code data differently, which hinder compatibility and comparability. Complex data representations. The data representing complex processes may induce errors in the extraction and analysis. So, for instance, if we have a procedure that may have 10 variations, not we have to, because of how, for instance, a surgeon does a surgery and has maybe 10 variations on that, then we need to be able to extract that information as 10 variations, not put it all in one big pocket and call it good. The volume of data. Large volumes of data can be challenging to work with, especially if you have limited computing power. Like I talked about that one IT gentleman who was doing all the reporting for that place by himself. It was like he was overwhelmed. And I think they had gone through several IT people because they would work for a short time, almost get burnt out, and they'd quit, and somebody else would get hired, would start up again, and it was kind of a mess. Changing data needs, and that's a big drawer, a big cause of poor data quality. Your data needs change, and they will change based on day-to-day operations, based on differences in processes, procedures, regulations, external stakeholder effect, internal stakeholder effect. If you have a hospital that has never been unionized and suddenly it's unionized, your data sets have to change because it has to take that into consideration. Believe me, it changes things. If your external stakeholders, if somebody suddenly donates, I remember the Sanford, Mr. Sanford donated, multi-million dollars to the Sanford hospitals on the west side or the east side of South Dakota. It changed how they did things. For instance, they changed their name, and it changed a lot of processes because he gave enough money that he wanted the focus to be on things he wanted them to focus on, and one of those was children's diseases. And so they established a whole new department, or expanded one, on children's diseases. And that's pretty important to understand. That's going to change, and you have to kind of roll with that. Excuse me. Now, to achieve high-quality data, it requires cooperation between the data warehouse managers, analytic team members, and the frontline staff. And they all have to be dedicated to ensure that all possible sources of poor quality data are identified, reduced, and eliminated. Now, people always want to say it's a person that does that or a group of people. And in my experience, that most of the bad data you get is system-based data, not individual-based data. Now, have I had to deal with individuals who just didn't give a darn and just put stuff in to get it done, and they didn't care what happened? Oh, sure, but I only had to deal with it for a short period of time because when they didn't self-correct, we helped them find a job in some other place, not our organization. We gave them an opportunity, so to speak. And so you need to really focus in on that and remember that most of the time it's a system problem, not a person problem. Having analytics and data warehouse team members in quality improvement and process improvement committees helps to ensure that any potential changes in data are taken into account during that change request discussions. Having your analytics people and data warehouse people in every single quality improvement and PI committee is essential. I can't tell you how important it is. Because you may say that you need 20 of these things in your process improvement team to make improvement, and the data warehouse may tell you that if those 20 things aren't accessible in the data. So you can't really tell where you're at or where you're going. It's pretty important. Data can't be locked into operational, divisional, or other information silos. Data has to be collected and stored so it's collaboratively stored between all systems. So if you have one system that's not sharing the data, then that means that you're losing out on that data. So that can't be. And data has to be managed across and between multiple source systems, which is kind of like saying that all over again. Now, data governance and management. Healthcare organizations need to have oversight for data collection, storage, and maintenance. And oversight authority and responsibility must be formally established. You just can't say we're gonna name John Jones as our data governance person. Well, that's great, but John Jones needs to know what his responsibilities and his authority are, because if he has no authority or no responsibility formally established, then he can go in and say, I want you to change this data, and the people in that department can say, well, I don't really work for you, I'm not gonna do it. And that sort of limits what the change in the management can. This prevents ad hoc data management processes and corruption of data. Oversight must be effective and flexible to ensure the data is high quality, accessible. So oversight has to be effective and it has to be but flexible. Now, healthcare organization data governance, according to the Data Governance Institute, data governance is a system of decision rights and accountabilities for information-related processes executed according to agreed-upon models, and usually that's by senior management, which describe who can take what actions with what information and when, under what circumstances, using what methods. In other words, it defines a who, what, where, and when process of getting of data. Who, what, where in collection, who, what, where, when in collection, who, what, where, when in maintenance, who, what, where, when in analysis and access. Now, the Data Governance Institute suggests a framework should include, it should possess a mission. So your Data Governance section, department, should have a mission statement. It should define focused goals, governance metrics, and success measures. It should outline clear data rules and definitions. It should enable decision rights, accountabilities, and control measures. It should identify data stakeholders and data stewards, and we'll talk about data stewards later. And it should establish a data governance office. It should implement proactive, reactive, and ongoing data governance process. Now, I'm a little sensitive when people start using the word reactive, because I think that management by reactivity is usually bad management. But sometimes a crisis will occur, and you need to be able to pull information out quickly to respond to that crisis. Let's say that a legislating body or a regulating body comes down and says, we think that your organization doesn't do these things. And you need to find out if that's true or not. And so you need to pull out that data and reactively be able to respond to that data or that accusation and say, well, do we do it 100%? No, but we do it 96%. So you're right, 4% of the time we're incorrect. We'll fix that, but this is not a major issue. This is a minor issue which we can correct. The data governance should establish, enforce, and refine policies and procedures for managed data at the enterprise level. That means at the COO, CEO, CFO level. Should establish and maintain data quality either by itself or as part of a larger committee. In other words, what often will happen is that data governance leader, whoever that is, a director or administrator, whatever, will usually use a larger committee to establish some of the parameters of the authority levels and responsibility levels that they have, as well as what they can do to make changes. They should create policies and procedures based on input from data owners, data stewards, analytic stakeholders, and business representatives. So their policies and procedures shouldn't be done in a dark room, but they should be done with those people in mind and having their input. And the bottom line is the data governance people, a department person should have the ultimate authority on how data is managed throughout the enterprise, period. That shouldn't be up for subjugation. Now, a data steward is a necessary component of data governance to ensure high quality and highly reliable data, and they're responsible for monitoring and evaluating data quality within the healthcare organization. And you may have for small organizations, you may have one data steward, and in the large organizations, you may have a data steward in every one of the large functional data areas. A data steward should have good technical skills, including the knowledge of data modeling, the data warehouse concepts, and they should understand the data and where it comes from and how it is produced that they oversee. So that should be, you can't just take appoint a data steward from one place and send to another. That doesn't work that way. Now, data stewardship, major functions of data steward include evaluating data quality, identifying issues, and making appropriate recommendations when there's a problem. They should ensure that any modifications to data storage and management are in line with established policies and procedures established by the governance body. And they ensure that data is used properly and is accessible, and they should help to establish enterprise-wide standards for data quality and usage within the governance group. Now, I put this in because this is right out of your book, and this is really important. This is enterprise-wide visibility and opportunity, and the need for agility and data stewardship. And I'm going to read this to some degree, not that you can't, but I really want to stop and talk about certain parts. The capabilities of health information technology systems are improving rapidly. For example, the emergency department information system at a typical emergency department when deployed several years ago may have started as only a patient tracking system for patients within the department. Additional capabilities are then added over time, such as clinical documentation, computerized provider order entry, and results reporting, including electronic prescription ordering. Other changes also occur throughout the organization that may be accounted for, such as renovation or expansions which require updates in location and business rules. And I'll stop here for a moment to talk about a certain example. When I was an administrator for healthcare for the University of New Mexico hospitals, I was in charge of the emergency room, and the emergency room was what's called a safety net emergency room. In other words, we took care of people who couldn't pay. And so what happened ultimately is the emergency room stopped charging for their services, even the people who could pay. So we were missing out on tons of revenue. The second thing is we couldn't document the care we were giving, the cost of care we were giving to people that couldn't pay. So that when we went to the state for reimbursement, we could in some cases, we didn't really have accurate data. So we redid we actually not only redefined the processes, we had to change we had to renovate the emergency room entry so that the people came in, they went through a different process, so they changed the processes. And we did all that. It was extraordinary. We started to show an increase in revenue, actual revenue, of about 40% in the first 3 months. It went up 40% in the first 3 months. It was ridiculous because what's funny was the chief financial officer used to show the revenue streams, and she'd always show the emergency room and always be really low. She had to change her charts to conclude this much higher level of return. The other thing that happened is we started documenting our free care, and the state felt so badly that we were doing that they actually passed a bill, a state tax, to reimburse us for that, because it was in the multi-millions of dollars every year. So it was pretty interesting. So we talk about other new technologies such as radio frequency identification might be added. The challenge is that many of these changes can and most often do impact the underlying data in the system. The radio frequency identification, the GPS system, if you will, which can maybe take your blood pressure anytime, it's sort of automated. That can really change because what you're collecting now is more data. The data steward within a healthcare organization must be responsible for ensuring that the data, whether it's in an enterprise data warehouse or otherwise, is up to date and has the latest data definitions, processes, and business rules. If any necessary changes are not communicated to developers of analytical tools within the healthcare organization, reporting analytical insight will soon lose validity. You'll start having data that's not trustworthy, and ultimately not to lose the value within the healthcare organization. So people stop trusting the data, they stop making the changes based on that data. Now the conclusion is data should be collected, stored, and managed and analyzed under formally established rules and regulations. Cannot say that enough. You'll hear me say it again. Trash in, garbage out. Data should also be accessible to those that require it, and data quality can be the difference of success and failure in quality improvement projects. Like we said earlier, good data doesn't necessarily guarantee the success of those projects, but bad data will almost always create a negative effect on those processes. Thank you very much.